Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
So if you're a surgeon or a doctor listening to this right now, you know this feeling. You're scrubbed in, standing over the operating table, scalpel in hand.
Right. The whole world just kind of shrinks down to the anatomy right in front of you.
Exactly. The monitor is beeping, the scrub nurse is passing instruments, and your entire brain is just focused on, local hemostasis, fixing the physical problem.
But there's always that invisible systemic web of risks hovering right over the field.
Yeah, and that's exactly what this deep dive is about. Today, we're unpacking a tool that is plastered across literally every single preoperative assessment. But it causes so much friction when a patient moves from the cardiology clinic to the surgical ward.
Yeah.
We're talking about the CHA₂DS₂-VASc score.
It is everywhere. And, applying this chronic medical risk score to an acute surgical situation, it creates a lot of tension.
It really does. But, hey, before we get too deep into the clinical weeds here, I have to give our mandatory disclaimer.
Oh, yeah, go for it.
The content we're discussing in this deep dive is for reference purposes only. You must always, always follow your local guidelines and institutional protocols in your actual clinical practice.
Which is super important today because the guidelines on this are actually actively shifting.
Right. So keep that in mind. But getting back to our mission today, we really want to figure out what this score actually tells you as a surgeon. And maybe more importantly, what it absolutely doesn't tell you.
Yeah, it's about balancing that thromboembolic hazard of atrial fibrillation against the immediate bleeding hazard of the surgery.
Because I like to think of the CHA₂DS₂-VASc score as well. It's like a long-term weather forecast for stroke risk.
That's a great way to look at it.
But surgery is like deciding to launch a rocket. The baseline weather forecast matters, obviously. But the immediate storm, which is the surgical bleeding, that might mean you have to ground the flight for a minute.
Exactly. So to understand how to manage that storm, we really need to break down the actual score itself.
Right, let's unpack the acronym. So this is estimating the risk of ischemic stroke or systemic thromboembolism, specifically in patients with non-valvular AF.
Right, non-valvular being the key word there.
Yes. So we've got C for congestive heart failure, H for hypertension, A for age, D for diabetes, S for prior stroke, V for vascular disease, and SC for sex category.
We've all calculated it a million times.
But looking at our sources, there are some persistent nuances that still trip people up. Let's start with the age brackets, because A is in there twice.
Yeah, it is.
So wait, if a patient is, say, 76 years old, do they get 3 points for hitting both age brackets? Because they're over 65 and over 75?
No, and that's a super common mistake when people are rushing an admission. The categories are completely mutually exclusive.
Okay, so it's one or the other.
Right. You get 1 point for being 65 to 74. Once you hit 75, you graduate to the 2-point bracket, and that 1-point bracket just drops off.
Got it. So the absolute maximum score is a 9, not higher.
Exactly. 9 is the ceiling.
Okay, that makes sense. But that brings us to the probably the most controversial variable lately, which is that SC at the very end. The sex category.
Yeah, female sex. The interpretation of this has completely fundamentally changed in recent years.
Because it used to just be viewed as a standalone risk factor, right? Like, you're female, here's a point, you're at higher risk.
Right, but contemporary data tells a different story. Female sex acts more like a catalyst in a chemical reaction.
Oh, I like that. So it's kind of like a multiplier in a video game.
Yes. A catalyst doesn't start a fire on its own, right? It needs combustible material. But once the fire starts, the catalyst just accelerates it.
So if a female patient has a score of 1, and that point is just because she's female.
She doesn't actually have an inherently dangerous environment that justifies blood thinners. That isolated variable doesn't provoke clots.
But if she, say, develops hypertension.
Right, now you have the combustible material. So her sex acts as an amplifier to that vascular pathology, making her stroke risk higher than a man with just hypertension.
Wow, okay. And because of this nuance, the guidelines are starting to geographically split, right?
They really are. Especially in Europe, there's a big push to just adopt the sex-neutral CHA₂DS₂-VASc score. Just drop the C's entirely.
Just to avoid the confusion of over-anticoagulating low-risk women.
Exactly. Because it's confusing to have a score of 1 mean you treat a man, but you don't treat a woman. Stripping it out makes it a uniform threshold.
But the UK and North America haven't totally jumped on that train yet.
No, recent UK guidance still leans on the traditional acronym. They just adjust the threshold instead. So they say, consider treatment for men at a score of 1, but hold off for women until a score of 2.
Which circles right back to our disclaimer. If your hospital audits you based on the VA score, you document the VAC score.
Exactly. Local guidelines always win.
Okay, so interpreting this in a clinic is one thing, but let's take this to the surgical ward. A patient is scheduled to go under the knife. The whole calculation just completely flips.
It does, and this brings us to the golden rule of perioperative management. The CHA₂DS₂-VASc score is estimating the thromboembolic hazard of AF over a long period.
And the operation is dictating the immediate bleeding hazard.
Right, and you have to remember, the score is not a perioperative bleeding metric.
So let's play out this standoff. You're a surgeon. You've got a patient coming in for a major bowel resection. Their score is a 6.
That's a high score.
Terrifyingly high, right? And they're on a DOAC, like a Pixaban. Obviously, you have to stop it so they don't bleed out on the table.
Naturally.
But staring at that score of 6, the clinical reflex is, well, we should be absolutely terrified to stop their anticoagulation. So bring on the heparin bridge, right?
Yeah.
Keep them safe while the oral drug washes out.
Yeah, and that instinct is just so deeply ingrained in medical training, but it's actually incredibly flawed.
Wait, really? Because bridging feels like such a solid safety net.
It feels like one, but it actually functions as a trap. We really have to look at the landmark bridge trial for this.
Okay, what did the bridge trial show?
It basically dismantled the practice of routine bridging for most non-valvular AF patients.
Because of the bleeding risk.
Right, because warfarin and DOACs take days to clear and days to start working again. But heparin acts fast, so when you bridge, you create these compounding, overlapping windows of incredibly thin blood.
Right when the surgical bed is just desperately trying to form primary clot.
Exactly. The trial showed that skipping the heparin bridge was non-inferior for preventing strokes.
So no extra strokes without the bridge.
Right. But, and this is the huge part, omitting the bridge resulted in significantly less major surgical bleeding.
Wow. So we were basically paying a massive penalty in surgical hemorrhage for, like, zero neurological benefit.
Basically, yes. The actual incidence of a stroke during a 5-day hold is tiny, but the incidence of a major bleed from aggressive heparin in a fresh wound is remarkably high.
So bridging is just out.
Well, not entirely. There are exceptions. If they had a stroke in the last 3 months, their risk is severe enough to bridge.
Okay, that makes sense.
And if they have a mechanical heart valve or severe rheumatic mitral stenosis, this whole scoring system goes out the window anyway. Mechanical valves follow entirely different, very aggressive bridging rules.
Right, but for standard AF, temporary interruption without a bridge is the way to go?
It is the standard of care.
Okay, so if we aren't bridging, what does a good surgical assessment actually look like in the notes? Because we need a checklist, right?
Yeah, you need a robust, documented plan. First, document the exact history of their AF. Second, calculate and write down the exact CHA₂DS₂-VASc score.
Makes sense.
Third, list the specific drug, the dose, the exact time of the last dose, and this is critical, their renal function.
Oh, renal function. That's the silent killer of surgical plans, isn't it?
It really is. A DOAC like dabigatran is heavily cleared by the kidneys.
So if you just say, oh, hold it for 48 hours, but their creatinine clearance is like 25.
That drug is still circulating at therapeutic levels when you cut them open. You have to use the Cockcroft-Gault equation to check their actual clearance to time the interruption properly.
Okay, and what else on the checklist?
Fourth, categorize the procedural bleeding risk and clearly state if there are neuraxial anesthesia plans, like an epidural.
Because you do not want an epidural hematoma.
Definitely not. And finally, the note should literally say, no bridging indicated, or explicitly justify the exception.
To stop the cross-cover doctor from panicking at 2 a.m. and prescribing therapeutic enoxaparin?
Exactly. It aligns the whole team.
All right, let's fast forward. We've done the preoperative hold perfectly. Surgery goes great. Patient is resting on the ward. But on post-op day 3, the monitor starts screaming.
Yeah.
New onset atrial fibrillation.
Classic. The body just went through massive trauma, fluid shifts, inflammation, pain. It's a huge systemic stress test.
It's like the check engine light turning on during a stressful road trip. But, you know, on the surgical ward, the temptation is to just treat the pain, assume it's a glitch, and wait for it to go away.
Right. But you can't just cross your fingers. The first step is to hunt for reversible precipitants.
Like sepsis or hypoxia?
Exactly. Are their electrolytes deranged? Is their pain out of control? Correct those physiological insults first.
But what if you fix all that and the AF is still there 48 hours later?
That's the threshold. If it persists, you bring the CHA₂DS₂-VASc score back out to quantify their risk.
So let's look at the case from our sources. We have a 78-year-old guy, just had an elective colectomy, history of hypertension, diabetes, and a prior TIA. He was on apixaban before, which we held.
Okay, let's calculate his score. Age 78 is 2 points, hypertension is 1, diabetes is 1, prior TIA is a heavy one, that's 2 points. Total score is 6.
That's a huge embolic risk. If he wasn't surgical, he'd be on full-dose blood thinners instantly.
Instantly. But he just had a piece of his colon removed.
Right.
He's got fresh anastomosis.
So we can't just reflexively blast him with full-dose apixaban.
No, immediate therapeutic anticoagulation here is incredibly hazardous. You have to look at the surgical bed. Are there drains? Is his hemoglobin dropping?
So how do we actually sequence this? Because we can't just ignore a score of 6.
The sequence relies on knowing the difference between prophylactic and therapeutic dosing.
Okay.
While the full-dose apixaban is on hold, you give standard prophylactic dose heparin to prevent DVTs, just like any other major surgery.
Assuming his hemostasis is okay for prophylaxis?
Right. But that low dose will not prevent an AF stroke. For that, you need the full therapeutic dose.
And when do we restart that?
Only when the primary surgical team definitively says the bleeding risk is acceptable. You do not restart full-dose blood thinners while a drain is filling with frank blood. I don't care how high the score is.
The local anatomical risk takes absolute priority until the tissue heals.
Exactly.
Wow. Okay. This has been a super clarifying deep dive. Let's rapidly distill this into some key takeaways for the doctors writing orders tomorrow.
Sounds good. Takeaway 1, never use the score for mechanical heart valves. They need their own aggressive protocols.
Right. Takeaway 2, do not use this score to estimate operative bleeding risk. It measures the thromboembolic climate, not the surgical weather. Use something like Hans-BLED for that.
Takeaway 3, stop justifying routine heparin bridging with a high score. The bridge trial proved it causes major bleeding without saving them from strokes.
And takeaway 4, write better pre-op notes, calculate the actual creatinine clearance, document the exact score, outline the interruption timeline, and write no bridging indicated.
Perfectly summarized. But I want to leave our listeners with one final kind of provocative thought about that post-op AF we discussed.
What's that?
We usually watch the rhythm revert to normal, discharge the patient, and call it a transient surgical response, right?
Yeah, temporary glitch.
But longitudinal data is showing that new onset post-op AF often unmasks a real underlying propensity for arrhythmias. Even if it resolves, it's strongly linked to a high risk of future strokes.
Wait, really? So the surgery is basically just a cardiac stress test showing us what was already there?
Exactly. So the question is, how many benign post-op arrhythmias have we ignored over the years? And how many of those were missed opportunities for primary care follow-up that could have prevented a catastrophic stroke 3 years later?
That is heavy. It really redefines our responsibility. We're not just managing them until the sutures are out. We might be uncovering risks that alter their whole life. That is definitely something for everyone to mull over the next time that telemetry monitor goes off.
Absolutely.
Well, if you like this content, please do not forget to share it with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages, and be sure to check our previous seasons and episodes for some very relevant topics. We will catch you all on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.